7 degrees as the horizontal plane is also commonly used. Since the introduction of 3D analysis, more landmarks have been proposed to construct reference planes. On the other hand, extracranial reference means true horizontal plane or true vertical plane, which is based on the natural head position. Since the Frankfurt Agreement concluded in Germany in 1884, the FH plane has been generally recognized as one of the most important reference planes for the skull, defined as a line drawn from Porion-orbitale. At that time, it was considered that the FH plane in most people was parallel to the horizontal plane when the head is in natural position. But later, many clinicians or researchers found it's not always true. There are 3 main shortcomings of FH plane. First, many researchers have indicated that an obvious deviation of the FH plane from the horizontal is common. Usually, the FH plane is more counterclockwise than the true horizontal plane. The deviation must be considered if the FH plane is selected as the reference plane. Second, for 3D analysis, it is difficult to locate the left and right orbitalis and porions, the 4 points on the same plane at the same time. And the alternatives are to use the midpoint of 2 points or to use the best fit plane. There is still no general agreement on this. And third, measurements based on the FH plane do not always correlate with clinical examination. A common debate of intracranial reference is the anatomical variation. Earlier 2D survival-metric studies have reported that intracranial landmarks are not stable points. The most famous FH plane have been reported as not suitable for being reference planes because of the large biological variation in their inclination. And both pronacism and retronacism studies show that intracranial reference lines are not so reliable. Later in his study, some authors have suggested that midline structures might differ from the true plane of symmetry. Facial asymmetry is usually due to supraorbital deformity, but facial asymmetry is usually due to suborbital deformity, but supraorbital area can also be affected. So even for endpoints, there might be some deviation. Also, the extent is very mild, almost less than 0.5 millimeter. And MS deviation is not uncommon, especially in cases showing maxillary asymmetry. Also, the extent of ANS deviation was reported to be significantly correlated with that of maintained deviation. Furthermore, change in the nasal symmetry has been found after maxillary repositioning in several studies. That is, the transverse position of subnasally as well as the nasal axis might change after OGS. Therefore, care should be taken when using nasal axis or other midline landmarks to construct reference planes for diagnosis and OGS planning, especially in patients with significant craniofacial deformity. The advantages of using natural head position as the reference to evaluate craniofacial morphology include first, stable and reproducible, not influenced by the anatomical variability. And second, measurements based on natural head position better describe the individual's true life appearance. Third, no need for intracranial landmarks. Therefore, natural head position has gained popularity with both orthodontists and surgeons over the world. And natural head position was first described by Broca in 1862. He defined this position as follows: when a man is standing and when his visual axis is horizontal, his head is in the natural head position. And in 1958, Morris and Kim defined it more specifically as a standardized and reproducible orientation of the head in space when one is focusing on a distant point at eye level. So far, there is still no universal definition for natural head position, but we're familiar with these two definitions shown on the slide. There is also no consensus on the contributing factors for natural head position. Personally, I prefer the simpler concept. That is, natural head position is a physiological position established early in life and influenced by balance, vision, and proprioception. I prefer not to consider about the pathological and the psychological factors because those factors might be corrected or improved after treatment. And the simplest way to obtain natural head position is to instruct the patient to look straight ahead at a point at eye level on the wall in front. And several studies have found the reproducibility was better if there was a mirror on the wall. In 1998, Cook reported the reproducibility of natural head position was quite good, around 2 degrees. Repeated radiographs, and the reproducibility was better if a patient was looking at a mirror. A small mirror is suggested to record natural head position because a small mirror can force subjects to look straight ahead into the image of their eyes. And the long mirror will preclude standardized head position, and we will get a non-standardized head position instead. And that is the patient's individual habitual posture. A more delicate technique for establishing natural head position was developed by Solo. They recommended patients to firstly walk around and relax, and the standing patient then perform decreasing forward and backward head oscillations before allowing the head to settle into a self-balanced position, and we get the self-balanced position first. And for mirror position, patients then are asked to look into a reflection of their eyes in a mirror at 200 centimeter distance and finalize their head position and that mirror position. And additional advice is that patient feet should be at a comfortable distance apart and slightly divergent so that patient's head might settle into the balanced position quicker. And different body positions result in different natural head positions. Standing subjects have natural head position that is less backward tipped than seated subjects, and the standard deviations were similar between standing and sitting, suggesting that accuracy did not depend on whether the standing or sitting position was used. It is difficult to conclude which position is better or correct. And numerous studies supported the stability of natural head position in the sagittal plane. Cook reported The natural head position reproducibility was 1.9 degrees after 1 to 2 hours and 2.3 degrees after 3 to 6 months, 3 degrees after 5 years. The following study further showed that there's a remarkable reproducibility of 2.2 degrees after 15 years. And natural head position has been found to be highly reproducible in both adults and children, in males and females, in Caucasians and non-Caucasians. The reproducibility for row was also good, around 1 degree. And Weber's study showed that natural head position was reproducible in 3 planes of space. The reproducibility is best for row, then is yaw and pitch in order. And another 3D study also showed high reproducibility of natural head position. In addition to self-balanced and mirror positions, this study had a third method to obtain natural head position, and that is estimated position. The researchers adjusted patients' mirror position until they observed no obvious tilt of the head in pitch or in row. And the conclusion was that the 3 methods are reproducible for both pitch and row, and the estimated position method shows the best reproducibility among these methods. And the authors also mentioned that the pitch reproducibility was a little bit higher, a little bit better than those reported in the earlier 2D studies. And the authors think the possible reason is that maybe it's a follow state, which means head holders might be used in the earlier 2D studies, and those head holders might interfere with the physiological balance and therefore reduce the reproducibility. And the shortcoming of natural head position is that sometimes it's very difficult to obtain the true natural head position. And many papers has mentioned about this kind of situation. And that is, despite careful instruction, a number of people showed a head position that experienced assessors consider to be more or less flexed, extended, or tilted. And repeated registration still show the same tilted head position. And just like this patient, the picture on the left side is the first time I saw this patient and took the records. At that time, I tried to suggest her to adjust her head to a more upright position. The head in the image was still a little tilted. And at the second time and third time, the middle and the right side pictures, I wanted to record this tilted head posture, so I didn't to try to adjust her tilted head. I just told her to be relaxed and show me her balanced head position. And that's the result. She showed, she showed a consistently tilted head position. I think maybe I got natural head posture, or other than the natural head position. The terms natural head posture and the natural head position seems to be interchangeable in some early studies, but in recent studies, those authors suggested that it's important to distinguish between natural head posture and the natural head position. And recent studies have tried to explain the term natural head posture. Also, there is no consensus on the strict definition of natural head posture. These authors did share some concepts in common. One paper said any non-forced position is a natural head posture for the specific activity at that moment. while natural head position is a standardized orientation. And the other paper said, and the other paper presented similar definitions. Natural head posture denotes a range of normal cranial orientation and an individual characteristic posture of the head. And that may vary to a greater or lesser degree from the natural head position. Both the natural head posture and the natural head position are highly reproducible, and it's quite important to recognize and to find the standardized natural head position from patients' habitual natural head posture in order to get proper diagnosis, treatment plan, and outcome. And this concept was described in detail by Nordstrom in 1995 as natural head orientation. And simply speaking, natural head orientation is a schematic natural head position. The author said, as repeated registrations revealed the same unnatural head position and adjustment of the head position in such instances was required to avoid clinically misleading findings. And this concept actually has been mentioned in earlier papers, like in the paper of 1876. And the clinicians also corrected patients' head to correct head position before taking cephalographs. But the term natural head orientation seems to be firstly introduced in the Nordstrom's study. And natural head orientation can be considered as a technique of establishment of natural head position in radiography or photography by estimation. Sorry. Or considered as the head position estimated by a trained clinician as the natural one. And the first step of natural head orientation is like recording natural head position. Let patients relax and and look at a distant point with or without a mirror. And then based on the general experience to subjectively adjust patient's head position until no obvious tilt is observed. Clinicians, photographers, radiographers all can be trained to make a critical judgment of the correct natural head position. And we can use photographs for training. I think not only clinicians, but also patients can be trained to recognize their upright head position. And both in the 2D cephalometric study and the 3D MD study, natural head orientation showed higher reproducibility than unadjusted natural head position. And this adjusted natural head position might include both correct and incorrect natural head positions. And incorrect natural head position could be considered as non-standardized natural head posture. And the high reproducibility is one of the advantages using natural head orientation. Another advantage is that it's a decision after comprehensive evaluation. Not only the intracranial reference, but also extracranial reference are taken into consideration. Or we can say it takes not only morphology, but also physiology into consideration. Generally, morphology and physiology has intimate relationship with each other. And in some cases, I'd like to take patients' preference, personal preference into consideration as well. And about the intracranial reference, originally to make the estimation of natural head position, clinicians were based on the craniofacial features or landmarks that are visible to the naked eye. And now we have CBCT tools and elder structures inside the skull now are visible. So I will take more structures into consideration when estimating the natural head position. For raw and view estimation, clinicians basically can evaluate the presentative landmarks for structures such as eyes, ears, nose, cheek, or zygoma. Evaluate their height, axis, and the amount of cheek shown on bilateral sides, or the projection of the cheek or zygoma on bilateral sides. And even the gross outline of the head can be evaluated. And if we are operating CBCT images, we can also take foramen magnum as well as other parts of the skull into consideration. Try to make these structures as symmetrically positioned as possible. And in this way, we might be able to detect or minimize the influence of situations like orbital dystopia or different ear height and so on. And clinically, I will check if the new head position seems natural and if patient is okay with that new adjusted head position, or if there is any discomfort with that position. And usually, patient will say they're okay with the new position and they feel similarly for the old and the new positions. And here's the example for raw estimation. Left side image is patient's habitual tilted natural head posture. And I try to make the upper half of face as symmetric as possible, including the eyes, ears, center of nasal root, and the nasal axis. These important facial features are the first priority. And right side image is the resulting estimated natural head position. Clinically, patient was okay with the new head position. Nothing discomfortable, nothing special. I also went back and forth within the axial slices of her CBCT model to check and to make most of the midline landmarks located in the mid-sagittal plane and the bilateral structures positioned as symmetrically as possible. And of course, not including the maxillomandibular region. And when there is conflict, midline structures usually are more important to me. And the patient's subnasally was on the left side of the nose. Subnasal was on the left side of the face. And I am not worried about this. First, the amount of deviation is quite small. Second, based on our previous study, subnasally usually will move toward the right side after we move the maxilla to the right side. And 4 months after OGS, clinically, her natural head posture was less tilted. That's shown in this picture. And I've been suggested her keep an upright and straight head posture. And I used the prop head position to check the treatment outcome. The symmetry outcome is quite good, as we planned. And the major goal of natural head orientation is to get the most harmonious, most symmetric face if possible. And there is a paper published in 2016 reported that facial asymmetry patients, the intrapupillary line became more parallel to a true horizontal plane after OGS. Patients' habitual natural head posture changed, and this study reflects the importance of natural head orientation before diagnosing and treatment planning. If the OGS plan is based on the patient's tilted head posture, the facial asymmetry will be undercorrected. And the spontaneous change of natural head posture may due to the change of the center of mass of the head or an alteration in the neuromuscular balance or self-awareness of the change of facial appearance. It's impossible to predict the change of head posture after OGS. Head posture is controlled by complicated mechanisms, and patient might change the head posture spontaneously, or we can suggest them to do so. And the other case is not a typical case. For this case, maybe it's not so critical to recognize which one should be the true natural head position. First, as the physiological aspect, patient felt similarly for these two head positions. Second, the overall craniofacial symmetry is similar for the two head positions. I've also checked the CBCT model. And in this case, patient preference was the key point deciding the final head position for OGS simulation. The left side image shows patient's habitual head posture and shows his right side eye and the right side ear are lower than his left side eye and left side ear, and nasal tip deviated to his right side. If I adjust his head position to level the eyes and ears and shown in the right side image, the nasal deviation will be more obvious, and the lower facial symmetry would also be more severe. And this could make the OGS plan more complicated. And in the end, he preferred the first position, and the OGS plan was designed based on that position. If patient is strict about the facial symmetry, we might choose the second hand position and need an additional rhinoplasty to treat his nasal deviation. And for pitch estimation, there are few clues to guide the clinicians. Facial morphology is not helpful in guiding the pitch adjustment. One paper showed facial morphology will affect natural head orientation judgment. Therefore, we should have other references for natural head orientation. Although using FH plan for pitch judgments seems not to follow the original concept of natural head orientation, because we cannot judge if there is head extension or head flexion based on the FH plan. FH plan is not a totally valid morphological feature. But personally, for pitch estimation, I still like to use FH plan for judgment. Also, clinical observation of the natural head position is also very important. Use the methods I just mentioned above to guide the patient to perform a natural head position, and a horizontal visual axis is a key point. When there is confliction in between, I generally favor the clinically observed head position if the position seems natural to me. Here's the example. When I adjust the pitch of CBCT model, generally, first of all, I will level the FH plane horizontally And for many patients, that position based on FH plan will be okay and will be similar to the position seen clinically. But for this case, the mandibular retrusion seems much more severe than what I see clinically. Clinically, patient's head position looks like that's shown in the right side image, with her visual axis being horizontal and the head position seems relaxed and natural. No extension, no flexion. Therefore, I will adjust the specific head until the pitch is similar to that shown clinically. And this is how I do the natural head orientation. And these are my personal preferences of how to estimate the natural head position in raw, yaw, and pitch. And then I can make a diagnosis and OGS plan based on this natural head orientation. Craniofacial team members can have a discussion together so that every member can adjust patient's head to a uniform position and can have a consistent diagnosis and treatment plan. And in summary, natural head position is a standardized and reproducible orientation of the head in space when one is focusing on a distant point at eye level, which is influenced by balance function of the inner ear vision and the proprioception. And natural head posture is an individual characteristic posture of the head that may vary to a greater or lesser degree from the natural head position. And the posture might be mistaken for the true natural head position. It is very important to recognize and not to use tilted natural head posture for diagnosis. And natural head orientation, which means asymmetric natural head position, is defined as the head position estimated by a trained clinician as the natural one. And natural head orientation takes into account both concepts of intracranial and extracranial references. Natural head orientation is highly reproducible and recommended for diagnosing patients with skeletal deformity or facial asymmetry. And the cases shown today, the head orientation is based on my personal preference. Different clinicians might have different preferences and treatment philosophies. That's all for my report today. Thank you.
Thank you very much, Dr. Chen. Thank you for your wonderful speech today. Any questions from the audience in the webinar? And please post all the questions in the chat room. Okay. In the time we are waiting for the further questions, I thank you, Dr. Chen, to give us wonderful explanations of the natural head orientation. One question from myself. You refer some cases in your practice to define your own ways about natural head orientations. Somehow they are all, I think they are all kind of a normal patients. So how do you judge about maybe the patient with the cleft? So in your opinions, the differences in the cleft patient and for the normal patient, do you have any different opinion in judge the natural head orientation? Thank you.
So far, my experience is not so much, but I think the way for natural head position, natural head orientation for these two groups are quite similar. Both intracranial structures and their natural head position, their natural head posture, their habits are considered.
Okay, thank you, Dr. Chen. Some questions that in our chat room now. So the first one is that the audience want to ask if you adjust the patient head and you only to adjust before the CT scan, right? When you adjust the patient's head and only before the CT scan or rotation the image afterward.
Oh, I rotate the image afterwards. I don't think it's necessary to adjust the patient's head when taking the records because eventually we will adjust it in software.
Okay.
But clinically, I will check if patient is adjustable, is comfortable with the new position.
Okay. Yeah. And the next questions, do you have any tips to how to orient the compensity of the patient to the NHO, natural head orientation? Do you have any tips?
Tips
Yeah.
for pitch. Yeah, it's just as I mentioned, as the cases I showed before, for pitch estimation for the lateral view, I will orientate the head firstly based on the FH plan, and also I will check the photos at the same time because the photos show the natural head posture of the patient and show her or their natural posture during real life. And I will see if the FH based head position is similar with that the patient naturally performed during their daily life. If the two positions are similar, then I will just use the FH based head position. But if there's confliction, like I just showed that case, the FH plan based head position showed the mandibular retreat is too severe, more severe than what I observed clinically. Then I will prefer change to the head position that I see clinically. Yeah, and from the frontal view to adjust the row rotation, I think the important facial features are important, like the eyes, the nose, the ears. I think these are the important features visible to patients and to patients' friends, family members. So I will try to make these important features. Those will not be changed by the OGS to be symmetrically positioned as possible. And I will look into the CPCT model to check another landmarks we are familiar with, like the structures. Yes. Or other orbital ring, upper border, lower border, to make them as symmetrically positioned as possible. And for your rotation, I will clinically make the promise, the projection of the cheek or the zygoma as symmetrical as possible. And also, I will look into the CPCT model to let the foramen magnum in the center position because it's connected to the spine. So I think it's important to put them in the center. Some tips like this.
Okay, thank you, Dr. Chen. One more question is following by the previous one questions. You mentioned you will rotate the image afterward if you judge the patient, but the audience asking, will it be possible to influence the CR relations during the taking the CT?
You mean condyle CR position?
Yeah, I think it mentioned maybe the CR relations. Centric relation. Centric relation.
The question is if I don't adjust the tilted head position and let the patient just directly to take the images, if the CR relation will be influenced. Usually when I'm not sure, but in our orthodontic team, I've checked with some doctors that we prefer more on the CO occlusion than CR relation. Yeah. So trying to record the CR position when taking the radiography.
Yeah. So the centric relation is taken during the combine CT, right, for the OGS scan.
I don't think so. I think many papers from our center, we also describe the CBCT acquisition method in the papers, and we usually describe the method as to let patient bite in the CO position and take the CBCT images, not the CR position.
Okay. Okay. Any more questions from the audience? Yes. So one more question from myself. For me, as myself as the surgeon for doing the orthognathic surgery, sometimes when we're doing the operations, if we only based on the surgical plan of the, maybe we did already discussed with the orthodontic doctors, we correct all the bony skeletons, the deformity. I think the bone is already be corrected. However, the soft tissue is still not in a good symmetric positions. So I'm not sure the orthodontics opinions if the surgeons making some differences the plan when we doing the surgery and not based on our previous discussion. So what is your opinion, Dr. Chen? How do you think?
I think I can say I nearly totally support the surgeon's opinion, surgeon's decision, because I think they're the ones who just directly see the results on the surgical table. Yeah, and they can revise the treatment plan so that the facial appearance will be the most harmonious one. I think that's good.
Okay, thank you for your kind response. We are more relieved now. So, okay, thanks, Dr. Chen-Feng Yao's explanations in our treating room. So in our Chang-Gung's Memorial Hospital, we scanned all the patients in the CO positions, just as Dr. Chen's suggest. All right. So if there are no more questions tonight or today's, I think we can conclude today's webinar so far. And thank you all the 60 audience today in this webinar with us for maybe 50 more minutes. So we have to say thank you again, Dr. Chen. Thank you for your wonderful speech with us in this very special topic. All right. 2 weeks later, we have another topic is talking about facial trauma, and we invited our another facial trauma professor, Dr. Howard Chen, to give up another topic. So please pay attention to our announce in our Facebook, and Nancy will release some of the information in our email for all of you. So thank you, good night, and good morning. See you. Bye bye. Thank you, Dr. Chen. Bye bye.
谢谢周，拜拜。
谢谢你，谢谢啊。
Bye, thank you.
谢谢罗斯。
Terima kasih.
Terima kasih.
Nice. See you next.
Thank you.
또 말하고 싶죠? 또 말하고 싶죠? 아는 게 많으니까. 들어버렸어. 아니까. 애기들부터 저는 안심. 애기들부터 저는 안심이야.